Reminder, you need to rule out for red flags. Patients may complain of lower leg pain, knee pain, or ankle pain. For lower leg pain, we need to rule out a possible DVT. During the history of present illness, ask about the history of any sitting for long periods of time, any long plane rides. Assess any risk factors, any prior history of DVTs, any birth control use, any smoking, any clotting disorders. Consider their age as a possible risk factor. For knee pain, one possibility is to rule out a meniscal tear. During the HPI, ask about the mechanism of injury. Do they describe any catching or locking of the knee? Any popping sound? Any sensation of the knee giving way? Any difficulty in straightening the knee fully? During the physical exam, you can perform one of these special tests, the McMurray test or the Tessely test. If the patient complains of ankle pain, we need to rule out a distal fibular fracture. During the HPI, find out what the mechanism of injury was. Was it an inversion or eversion ankle sprain? Are they able to bear weight on it? Were they able to bear weight on it immediately? During the physical exam, do they have any tenderness on the distal end of the tibia or fibula with palpation? Do they have any pain over the fifth metatarsal? Know the Ottawa ankle rules in order to know when an X-ray is indicated.
So if the patient comes in complaining of any kind of hip pain, there are a few simple techniques, assessments that we can do. So we can check for the internal and external rotation of that hip. So we can assess internal, external rotation, and make sure that we are internally and externally rotating the hip joint, not the knee, not the ankle. We can assess the other side. And this hip is definitely externally rotated. That would be the diagnosis. It's having some restriction with internal rotation. So really simple, using our muscle energy concepts, we can put it into the barrier and ask the patient to rotate their hip out. So I'm going to put your leg in, and I just want you to rotate your hip out against my force. Rotate your hip out for me. For 3, 2, 1, relax. Put it further to that barrier. And you can adjust your hands as needed. And rotate your leg out for me for 3, 2, 1, relax. And one more time for 3, 2, 1, relax. And then you reassess. Another way that we can do it is using still technique. So if the leg is externally rotated, you're going to grab the leg up, put it through its motion into the barrier. So we're going to take it into the freedom and then into the barrier. So I bring the leg up so it's externally rotated. And remember, you're adding some compression, the correct vector, to that hip. And so we're going to bring it up with some compression into that external rotation and bring it all the way around, maintaining that compression into the barrier, which is internal rotation, and then you would reassess. So if the patient is complaining of any kind of knee pain or ankle pain, we can evaluate the fibular head. And to evaluate the fibular head, you can evaluate one side at a time, right? find that fibular head. There's a tibial tuberosity here. You can come laterally to it. And take your time. Really look like you're looking for these things. You're going to push it posteriorly, push it anteriorly, and you can assess the other side. Compare the two sides. Another way you can do it simultaneously is by finding them on both sides and just wiggling them, figuring out what doesn't have motion, what feels restricted. So to review our mechanics, if this is posterior, the distal end will be anterior, and this usually happens with a supinated or inverted ankle sprain. And remember, plantar flexion as well. So we have inversion, supination, and plantar flexion. If this is anterior, this will go posterior. We have dorsiflexion, eversion, and external rotation. So with those mechanics, we can do muscle energy. Evaluate both sides, compare them. If she's complaining of this side, figure out the diagnosis. So we'll just demonstrate if she has a posterior fibular head. This is posterior, this is anterior. We want to put this into the barrier, so we want to put it posteriorly, and we can do that with dorsiflexion, external rotation, and eversion. And with your other hand, you are going to encourage that fibular head to go anteriorly. So I want you to push down, like if you're pushing on a gas pedal, push all the way down, just match my force for 3, 2, 1, relax. Push it more into the barrier, and push this one more anteriorly. Just match my force, push down for 3, 2, 1, relax. Push it further into the barrier. And one more time for 3, 2, 1, relax. A little bit of a passive stretch, you bring it down, and you reassess. Compare both sides. Another thing we can evaluate is the tibia. The tibia can be internally rotated or externally rotated. So you can evaluate one side at a time if you'd like. And you really grab that tibia and you're going to bring it out, bring it in. Figure out what hand placement works best for you. And as I'm evaluating her, this one actually feels like it is externally rotated. So we put it into the barrier. Internally rotate. I want you to bring your leg out like this. Bring it out. For 3, 2, 1, relax. You bring it further into the barrier and rotate your leg out for me. For 3, 2, 1, relax. And one more time. For 3, 2, 1, relax. And you evaluate both sides. There's definitely more motion there. And that's how we can evaluate this region. If they have an ankle sprain, any kind of knee pain, assess the fibular head, assess the tibial rotation, and you can do your muscle energy treatment. So if your patient comes in complaining of any kind of low back pain or hip pain, we can do what we taught you guys in lab for the past 2 years while you were in school. We can do the standing flexion test and assess from there the PSIS heights, ASIS, check pubes, and go from there to see what it is exactly that we need to treat. So let me have you stand up for me and face the wall. I'm just going to assess back here. So you go to the iliac crest, you come all the way down, and remember, take your time. So to assess for PSIS, you go to the iliac crest, and you're going to palpate down, and take your time with it. You know, no one should rapidly find the PSIS. Remember, for men, it's usually closer together. For women, it's further apart. If you're having some difficulty, you can ask the patient, can I lift your shirt up? And some patients take longer than others. And here we can assess PSIS height. So just keep note in your head which one is up, which one is superior, which one is inferior, and ask the patient, can you bend forward for me? And come back up. And the one that moves the most would be the positive side. So take note of all the things that you have found. Ask the patient to lay down. And so as they're laying down, we can assess the ASIS. Is it okay if I palpate down in this region? You let me know if anything is uncomfortable to you. Just going to touch on your hip bones. And here, remember, if you're right eye dominant, that you're on the correct side of the patient. And so this one, again, evaluate which one's higher, which one's lower. And to assess the pubes, is it okay? I'm going to touch your pubic bone. Is that all right? Yeah. If there's any tenderness or discomfort, you let me know. So start up at the umbilical. Come all the way down and keep pressing down until you feel, and there's a bone. Is there any tenderness there? And you can assess for asymmetry. So let's say the patient had some tenderness or some asymmetry at the pubic symphysis. A treatment that we can do is the pubic treatment. So I'm going to have the patient bend both of your knees for me. And this is a muscle energy treatment. Make a fist, and you put it between the knees, and you have the patient squeeze your knees together. You can hold this for 3 to 5 seconds. And relax. I'm going to swivel the knees a little bit. And then you hug the knees together and you ask the patient to spread the knees apart for 3, 2, 1, and relax for me. And I can swivel the hips again. And then the last one, I'm going to put my forearm between your knees. I'm going to have you squeeze. Is that okay? So you put your whole forearm in and have the patient squeeze again for 3, 2, 1. Relax. And again. And you help them bring the legs down. And then reassess the pubic region. Is it okay if I touch again? Again, to begin at the umbilical region and palpate all the way down. And you can assess for the asymmetry again, or if it got better, if it got worse, if the tenderness is still there, is it less? So because this is resetting the pubic symphysis, it's also resetting the SI joint. And because of those mechanics, we have to reassess standing flexion test, PSIS height, and ASIS height. So can you stand up for me again, and we're going to do the same thing. Can you face the wall? You would come back, again, take your time. Iliac crest. Is it okay if I put your shirt up? way down, find the PSIS, check those heights, ask the patient to bend forward again, come back up, assess, has it changed? Is it different? Have the patient lay down again. Again, can I palpate on your hip bones? Okay, you let me know if anything is uncomfortable or tender. And again, I'm right eye dominant. And you assess for ASIS height. So just to review, let's say we have an anterior rotation. If we have an anterior rotation, rotated innominate on the right, what we're going to do is the muscle energy treatment. With this hand, I'm going to have my thumb on below the ASIS and wrapped around that hip. And with the other hand, we're going to flex the leg up, and you put your hand behind. And remember, we want to activate those hamstrings to bring that hip into some posterior rotation. So what I want you to do is push your foot out to the wall. So push against here. I'm going to put my hand back here. So push your leg out for me. For 3, 2, 1, relax. And bring it further into the barrier. And push it out for me for 3, 2, 1, relax. And one more time for 3, 2, 1, relax. Bring it down. While you're here, you assess again. ASIS, you stand them up, you assess the PSIS height, and a standing flexion test. Just for sakes, we're going to keep demonstrating different techniques. So let's say this was a posteriorly rotated innominate. I'm going to do it on this side. Can you scooch over to this end of the table? So let's say she has a left posterior rotated innominate. We bring the leg out and bend it. And we stabilize the opposite hip at the ASIS. And we ask the patient, can you push this leg up to the ceiling? For 3, 2, 1, relax. Push up again for 3, 2, 1. And one last time, push up for 3, 2, 1. And again, I go to the side of my right eye dominant, assess ASIS, we're going to stand up the patient, assess PSIS height, and do the standing flexion test again. So let's say you evaluated and you saw that this person has a right superior innominate shear. We're going to come down to the end of the table. We're going to grab that leg and remind the patient, don't help me, just let me know if anything's uncomfortable. You're going to abduct that leg until you feel some restriction. And abduct some restriction, and you're going to go right to the middle of it. We're going to internally rotate. And remember, internally rotate at the hip so we can gap that joint. And then we're going to ask the patient, can you pull your right hip up? For 3, 2, 1, relax, and pull it further into the barrier. Pull your hip up again. For 3, 2, 1, relax. And one more time, pull it up for 3, 2, 1, relax. Bring it back. And again, assess ASIS, stand them up, assess PSIS, and do the standing flexion test. If they had an inferior innominate shear, what we're going to do is come down to the end of the table, and you can place that leg on your hip, and you can push it into its barrier. So if it's inferior, we're going to push it into to put it superiorly. And so what we can do, just stabilize this leg, and we can have the patient push down on this foot for me at your hip. Push your hip down for me for 3, 2, 1. And push down at your hip. So make sure they're not just doing their feet. Make sure that they are actually pushing that hip down. And relax. And push down at your hip for 3, 2, 1. And relax. Another thing you can do is stabilize the leg here, put it into that barrier, and treat the opposite leg as if it were a superior innominate shear. So if this is inferior, this one is superior. We could treat this one as if it was a superior shear. Because you're treating the opposite side of the standing flexion test, you need to vocalize and verbalize what it is that you're doing so that the graders understand what your reasoning was for treating the opposite leg. So this is an inferior innominate shear. You can come over to the other side. Bring that leg out again into abduction. Find that softening spot. Internally rotate that leg. And you pull it inferiorly. And pull your left hip up for 3, 2, 1. Relax. And you pull it out. And pull that left hip up for me for 3, 2, 1. Relax. And one more time. 3, 2, 1. Relax. And again, explain to the patient, be like, your hips are like this. I'm going to bring this one here, this one down. All these things, these are great ways that you can talk to the patient and just, again, vocalize if you're going to treat that opposite hip. And again, you would reassess. Check ASIS, stand the patient up, check the PSIS level, and do the standing flexion test.